Hello, everyone, and welcome back to another session with Dental Shadowers. Today, we have an exciting session with Dr. Bonaiuto. Dr. Bonaiuto, thank you so much for joining. And on that note, the floor is yours.
Hi guys, I'm pretty impressed that you said my name correctly. It's a rare occasion.
I actually watched a video before to pronounce it. I didn't want to mess up.
Well, hi everyone. I am joining you. I'm an orthodontist, and I really want to say that I admire what dental shadowers have put together. It's pretty amazing that this is an amazing resource that you guys have put together for everyone who just really can't experience not just shadowing, but school the way that it should be experienced. This has been like a crazy year for, I think, everyone in different ways. So kudos to you guys. I am from the East Coast. I was born and raised in Brooklyn. And I do currently practice most of the time in Brooklyn. And I have like a little side job gig in Fair Lawn, New Jersey. I am married and I have two children. I have a 2.5-year-old daughter, and I just had a baby boy 4 months ago. So I'm tired.
Congratulations.
Thanks. I graduated from Fordham University in 2006. That was my college, and I was actually a history major. So I know that most people going into pre-med, pre-dent with the plans of going on to dental and medical school do like a bio major or a science major. And I really hated science and I did not want to major in it. And so I loved history. I figured it was one of the only times I was going to get a chance to learn more about it. And so I did my history major and I did a business minor, which was advice from a dental friend of mine who said, the one thing you really don't learn about in dental school is business, but everyone becomes a business owner pretty much. I mean, most people who are dentists, orthodontists, specialists wind up becoming a practice owner. And a lot of that is a portion that you just really don't get to experience and get to be taught about in dental school. And it's a major thing, you're not just in the dental field, you're in the business of running a business, which could be really hard for some of us that just don't have that mindset. And then I did my pre-med on the side. So I was pretty busy in college, taking a lot of credits. It was nonstop and I was a commuter, so I didn't stay on campus. And that was kind of hard for me, which means I was basically studying and commuting and working all the time. So college was kind of like a job for me. I went to UMDNJ after that. It's Rutgers now, but I think I was the last graduating class that it was UMDNJ in 2010. And then I did a 3-year residency where I earned my orthodontist certificate also at UMDNJ. So I stayed on for 3 more years. And I am board certified. So every specialty has a board. We have the American Board of Orthodontists, and it's a choice to become board certified after you graduate. And it's definitely something prestigious. I feel I'm definitely proud of myself for taking my cases to the board and presenting them in front of my peers and having my peers say, yes, we think you're a superior orthodontist, and you get your board certificate. So not every orthodontist is board certified. And it also doesn't mean that those who aren't great orthodontists. It's just like one extra thing that you just do, I think, mostly for yourself more than to say, hey, I'm board certified, I'm better. I don't really think that's the case. So getting into dental school, I feel like some of this is a little different now. I mean, when I was applying to dental school, it was like 2004, 2005. And so, sorry, it was even earlier. Oh my God, I'm so old. So, a lot of the things that you guys need to do is probably a lot different. And I also think that maybe you may have a lot more competition now. And especially if you're graduating or applying this year, you have a whole different world. I don't even know how admissions is going to be looking at people who are applying now, because there's a whole year to take into consideration where everyone was just not being engaged education wise that they should have been. But of course, they're going to be looking at your grades. And so you're going to want to have the best that you can. You're going to take a DAT and a PAT. So they're going to be looking at those scores. It's your dental, your DAT is for your dental, and then there's your perceptual ability test. There's a PAT portion for dental school. And that is important because, yeah, we want to make sure that our dentists are really smart, but we also want to make sure that they're really good with their hands. Okay, so you really do need to take into consideration hand-eye coordination. A lot of dentists and specialists that you know probably are musicians, or they have artistic ability, or they're woodworkers, or they're, you know, they do construction on the side. They're really good with their hands. They have great manual dexterity. They have an eye for art and for putting things together the right way. And especially orthodontics, a lot of that is artistic ability. And so it's something to think about if you're thinking about going into dentistry. This is a portrait of my nephew that I drew, and I do one of all my nieces and nephews, but I'm way behind and I'm probably never going to get to my own children. So, but this is just an example of some of the things that you'll see dentists, they dabble in on the side. Also work experience. So I actually worked for a dentist for a really long time. So that was something great to put on my applications. But any work experience, I think, is important. You know, these people are going to be looking at your applications, and they do want to know that you're smart and that you're interested in dentistry, but they also want to know that you're real people who have work experience and real life experience, and work experience of any kind says a lot about a human being, beyond just what kind of work it is. So even if you're working at McDonald's, or you're on the floor at Abercrombie and Fitch, or whatever, you're learning how to work with people, you're learning how to earn a paycheck, and having a job and having work experience of any kind definitely says something for the kind of person you are, I think. Extracurricular engagement, of course, you want to join clubs when you're in school, and you know, they want to see that you're not just studying, that you have time for other things in your life. I did not do any of that in dental school, in college, because I was working. I worked 2 jobs, so I didn't have time for a lot of extracurriculars, but work was my extracurricular. And then your recommendations that you're going to get from your professors and maybe your employers. Research, also something I didn't really do, and it wasn't really big, I don't think, when I was applying, but I think it's huge now. I know some high school students that are doing research, and they're starting that early. So if you can get involved in research, and if there's a committee, or if there's a department that does a lot of research and you can get involved in that, I would recommend it. It's really great to put on, and a lot of people are doing it. And I know some people would do like mission trips and stuff, go to other countries, volunteer work. So I think anything extra you can put on besides just the typical is really great to show whoever's going to be looking at your applications. And then getting into orthodontics is kind of similar, I guess. I mean, your grades and your class standing are going to count a lot. This is a picture of my mom getting her Invisalign. She's probably going to hate this. So your grades and your class standing, I think, count for a lot. They did for me. So it was the 2 people that got into the UMDNJ from my class were the two highest class standings, me and another girl. So when I applied, your board scores were important, and they were not just pass fail, and now they're pass fail. So maybe they're not as important now. Obviously, if you're applying, I hope you've passed your boards. So your recommendations from your professors. School club involvement actually is pretty important once you're in dental school. And I think that it's something that is important for your applications. Maybe wasn't as important in your dental school applications, but I think for your specialties it is. Shadowing, obviously. So whatever you have been able to do before COVID shut down, but doing this now is definitely helpful. Research, again, is really important. And GPRs are becoming really popular. So a lot of specialty programs are actually requiring that you do a GPR before you apply. And that just means that you go out and you do a general practitioner residency of 1 year, typically. before you start applying. So they want to see that um, that you know more than you did when you walked out of dental school. And everyone walks out of dental school thinking that they know so much. And then you hit the real world and you have a lot more patients, and your schedule is more demanding. And you're like, wow, I really needed this extra year to really hone in on my skills and learn a lot of the things that are really isolated when you're in dental school, but aren't really like the real world once you get out there. The situations that you're in and the patients that you see maybe aren't so cookie cutter the way that it's presented in dental school. And so, you're really thinking on your toes and working really hard outside of dental school, and a GPR is going to condition you for that. And even 1 year, you'll see, is just not enough. You're just really never done learning, but doing a GPR is huge, and I would definitely recommend it. And I think a lot of programs are leaning towards requiring that now. So something to think about. How to choose a specialty? Well, obviously doing what you're doing, learning from all of these doctors that are giving these presentations is a really nice way. Working, I don't know if any of you have before COVID had an opportunity to actually work in some of these offices. But that's work experience in the dental field is always important. And take advantage of your faculty. A lot of your faculty, when you're in dental school, are not just general practitioners. They are periodontists and endodontists and oral surgeons. And really getting to know them and picking their brains and asking if you can come to their offices is a huge resource. And they want to help. I mean, if they're at your school teaching, they are people who want to be involved in your lives, and they would love to see that you are interested in learning more about the specialties. And they are a huge resource. Consider the lifestyle. So every specialty has a different lifestyle. If you're going into oral surgery, maybe it's going to be a more demanding workload than orthodontics is going to be. I work 3 days a week now. It's really pretty awesome. And physically, it's not as demanding as an oral surgeon's life might be. And so you may want to take that into consideration. So I thought about oral surgery. It was actually the only specialty I was interested in before I chose orthodontics. And I just wasn't really sure that I wanted to do another 4 to 6 years of school after school. I mean, if I was going to do OS, you can do a 4-year residency or a 6-year residency to get your MD in addition. And so if I was going to do it, I was going to go for the 6-year residency. And was I really waiting to start my life at 30? That's what was going to happen. You were going to finish your residency at 30. It's a very demanding residency. It's very physically demanding. You're in the OR, you're on call a lot. So those are things that you have to think about. Yeah, maybe you love oral surgery when you're in school, but you're just getting a small taste of it. And so think about your long-term plan. So envision what you think you want your life to be like in 5 or 10 years and see what fits into that. Because by the time I was 30, I was thinking, okay, I'll probably be married and have a kid or 2 or whatever that is. And so I don't know if oral surgery was really going to afford that to me the way that I envisioned it in my mind. And so I moved away from oral surgery. And especially for females, I mean, it is a little different for females and males. I mean, for any gender, orthodontics is great. You can set your own schedule. If you want to work 6 days a week, you can. If you want to work 2 days a week, you can. You can create your own workload. If you want a certain practice where you're going to have a high quantity of patients, high volume, and you want to see 150 patients a day and work until 8 o'clock, go for it. If you want to work until 2 and see 12 patients a day, go for it. And there's ways to work around that to still make it profitable for you. Orthodontics is great. It's a makeover every day. So you are dramatically impacting people, especially the adults. They come in because they want to be there, not because their parents drag them in. And so the amount of people that you'll see crying in your chair because they are just so grateful that they could do this and you've done this for them is huge. And orthodontics is a little different than some of the other specialties because every single patient that you see is different. Every single patient has their own issues. And every time you see that patient in your chair, it's not just like, oh, this is a no-brainer, blah, 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 blah. I'm going to put in this wire today and send you on your way. Every patient's different and you're thinking on your toes. You are presented with a problem or an issue or something that came up that you weren't expected to see. And you have to think in the moment about how to change it, whether it's just moving one tooth a specific way because the patient's supposed to get their braces off some next time, or if they have a skeletal problem that presented itself mid-treatment and you didn't anticipate for it. So there's a lot of things that just keep you on your toes. It's a puzzle, it's a brain teaser, and it really keeps your mind working constantly, which is, I think, exciting. It's not just, for me, I didn't love endodontics. That seemed very repetitive to me. And so this is a little different in my opinion. I don't mean to offend any endodontists out there, especially for females. Orthodontics is an amazing specialty. Like I said, I used to work 6 days a week, but now I work 3 days a week. Once I had kids, I didn't want to be hustling like that. And so I still make a very nice paycheck and I don't have to be in the office every day. And if my kids go to school in a couple of years and I want to be working a little bit more, I can. So that's something that dentistry as a whole affords you versus maybe some other careers that could be chosen. On the flip side, though, you know, my friends that work in corporate get like 4 months off for maternity leave, and I'm lucky if I take 4 weeks off for maternity leave because most of the time you're working for a small practice, you're needed. If you don't own your own practice and you're needed like in 1 week, I'm an associate, but you're still needed. And so a 4-month maternity leave is maybe not something that is going to be smart when you have patients that are waiting to be seen. So there's pluses and minuses, but I think on the whole, it's a really beautiful thing. And so how did I choose? Well, I started working as a dental assistant when I was 15 years old. My mother was like, listen, you need to get a job. I had a single mother and she was like, you want stuff, go to work. And so I had a dental appointment that day and I overheard that they needed help in the office and I was like, I'll help. And they're like, no, you're 5, you can't help. And so I called them every day for a week until they were like, come in and stop calling us. And so I showed up and I was like, I'll do anything. I will put away your charts. I'll clean your instruments, like whatever you need me to do. And so I never looked back. I started working for them. I also was working another job at a restaurant as like a coat check and a hostess. And I worked for my dad occasionally. And so I was really working a lot from a really young age, and it taught me a really strong work ethic. But I loved dentistry. I loved the workday. I loved having a family of patients that you see, whether it's every 6 months or it's every 3 weeks. And it was exciting. I mean, there's always some people that are going to come in that you're like, this person is someone I would not like to see every week. But most of your patients are great and it's exciting and you're engaged with them and it's fulfilling. You're helping them out. Most of the time, people are leaving happier than they came in. So I loved it. And so that's how I decided to go into dentistry. Once I was in school, like I said, I was thinking about oral surgery, but I kind of figured out that that was not just going to match my lifestyle that I envisioned for myself. And I was in school over summer break, applying, getting my stuff together for GPRs. And a mentor of mine called me into his office and he was like, why aren't you going to orthodontics? And many of you don't know this, but when you're in dental school, you don't really learn anything about orthodontics. So orthodontics seems really boring. It's a concept that's hard to wrap your head around because at face value, it seems like it has nothing to do with teeth and everything that you're learning about for 4 years. And so, you know, you really don't develop an interest in it unless you already know that you want to do it. Like there are some people who are like, I loved my orthodontist when I was 12 and I want to be an orthodontist. That wasn't me. So, I mean, my orthodontist was cool. never thought about it. And so in dental school, I also didn't really think about it. I was like, definitely not orthodontics. And he was like, listen, you have the grades, you have the scores, you have everything that you need. Like, don't miss this opportunity. Don't be stupid and apply. And I went home and I think I cried for like a day. And my fiance, now my husband, was like, you want to apply to orthodontics? You don't even like orthodontics. And I'm like, I know, but I think I'm going to miss out on this opportunity. And it was August. I missed 95% of the schools that could be applied to. All applications were closed. I only applied to 3 schools because I missed everything. And I got in, and it was great. And it was the best thing that ever happened. And one day I'm going to buy that mentor a house or something because he changed my life. And I love orthodontics more than I ever thought that I could. And it was an amazing chance meeting, and I took a leap of faith and I never looked back. So work experience, when I graduated, I worked 4 different offices. You'll see this is pretty common, I think, across the board for dentists generally. And I was working 6 days a week. I was just hustling. I was like, I'm poor. I am in so much debt, and I just need to work as hard as I can while I'm young and I don't have kids. And I just did as much as I could do. And so I worked 4 very different offices, which was really good because you learn 4 different types of offices. So one was for a GP. I was the only orthodontist there. I actually still work that job, and I love it because I'm the only orthodontist, and I get to just kind of like hone in and do whatever I want, which is really nice. I worked 1 higher end non-insurance. I was one of 3 orthodontists there. And that was also really nice. You see a lower volume of patients because it's a non-insurance. So these patients are typically paying more for their cases. And you're generally doing higher quality of orthodontics, mostly because you can spend more on your materials and you have more time with each patient. So I worked in a Medicaid type office, which was very high volume, very fast paced, very little time with each patient. And I would say that teaches you how to keep on your toes real quick and think really fast about how you're going to make each appointment as impactful as possible for each patient. And then one just like a middle of the road normal insurance practice and I was the only orthodontist too. But now I only work 3, sometimes 4 days a week. I do 2 practices. I still have that GP practice like a couple times a month, which I love. And then I'm one associate of a 3-doctor practice in Brooklyn. We have 1 owner and there's 2 associates there. And I love that job too. And we do really high quality orthodontics. We see maybe 100 to 120 patients a day, depending on what the day is and how long the day is. And so it's a little bit different in each office. What is orthodontics? Well, it's a specialty that deals with the diagnosis and the prevention and the correction of malpositioned teeth and jaws. So I think a lot of people think that we just deal with straightening teeth out, but it's actually more an orthopedic profession. So a lot of it focuses on facial growth, especially for our younger patients, and how we can modify that if it's not going in a perfect direction. And then we deal with craniofacial syndrome. So we have a lot of cleft palate patients. This is an example of a patient with cleft lip, cleft palate. And we have a lot of patients like this. And then there are some that are on a more severe spectrum. There's Cruzon syndrome, Appert's, Treacher-Collins, cleidocranial dysplasia. I don't know if anyone watches Stranger Things, but that kid has cleidocranial dysplasia. He's like that main character. I don't know his name. And so that's another really common syndrome that orthodontists have to deal with, and probably pedodontists. So a typical day in orthodontist maybe is a little different than some of the other specialties, definitely different than just a general practice office. So We tend to see a much higher volume of patients. Our offices also tend to look really different. You know, when you go to the dentist, you probably get sat in one room, and all of the instruments are in that room, and you're separated from all the other patients that are there. A lot of orthodontic offices, you're in a room with maybe 5 or 6 or 12 different patients because the chairs are all right next to each other. Maybe there's a divider between them. So it's set up a little differently, and we're seeing mostly patients for their adjustments because they already have their braces or their Invisalign, and they're just coming in for a quick 15-20 minute check to have their wires changed or their aligners looked at. And so you're seeing a lot more patients in a day versus maybe a GP is seeing, one GP is seeing maybe 20 to 30 patients that day. Also, we have a mixed bag. So I think everyone thinks that orthodontics is just for kids, but it's not. We have a lot of adult patients. We're at probably 40% adults now. Maybe you could even stretch that to 50%. My oldest patient was 83 years old. She had all her teeth. So she did Invisalign. And your assistants are crucial. So, you know, I was an assistant for a dentist, and I kind of just sat there with the suction, and I took impressions, and I cleaned instruments. Your dental assistants for orthodontics do a lot of work. A lot of what you want done to that patient is you dictating that to your assistant, and your assistant follows it through. So if I want to change wires and change the elastics and have something done to that patient, I just let my assistant know in a lot of cases, and it varies from state by state. But your assistant actually follows that out, which enables you to see so many patients in a day. And so you're kind of just like the brain power, and your assistants are crucial. Our assistants are the bomb, and they're crucial to making our office go around. And that's something that's a little different with orthodontics than maybe some of the other specialties also. We do consults in a day. Some of our longer appointments would be bonding appointments, so putting braces on or taking braces off. We do some specialty procedures like gingivectomies or placing TADs, and I'll go through this a little later on. But the majority of our appointments are adjustments, and so those are shorter appointments. The types of problems that patients come in with are one of usually 3 concerns. So either they come in, or their dentist sends them in, or an oral surgeon sends them in because there's an issue. And most of the time it's that they don't like how their teeth look. So it's an aesthetic concern. A lot of the time patients come in because their teeth are either really crooked or crowded. So you can see that in this upper photo, or maybe they have a lot of spacing, which is in that lower photo. Or sometimes patients will just say, there's one tooth that's always bothered me, it's sticking out. And so there's an aesthetic concern that they're there to see you for. Maybe they're there to see you because they have a bite concern, or a mixture of the previous concern with this. So I mentioned that we do orthopedics. Well, a bite concern is the way that your top jaw and lower jaw fit together. And that could be dental related. So it could just be a problem with your teeth, or it could be a problem with the way that your skeletal makeup is. So your top jaw skeletally could be malaligned with your bottom jaw skeletally. And so that'll be represented in the way that your teeth fit together. So this patient all the way on left has 3 of these problems. She has a class 3. That means that her lower jaw is more prominent than her upper jaw, so it sticks out. She has an open bite, meaning that her top teeth don't meet or overlap with her bottom teeth. And she also has a cross bite. So if you look at her back teeth, her top teeth are on the inside of her bottom teeth rather than fitting out and over her bottom teeth. So your top teeth should fit out and over your bottom teeth like a lid on a shoebox. And sometimes that's the opposite. And if you ever try to get a lid that's too small on your shoebox or your Tupperware, it doesn't go down. And so this patient has that. The patient on the right is a deep bite patient. And so you can see how she's progressed through her treatment, but her top teeth in that top photo completely cover her lower teeth. You can't even see them. It's 100% overbite. So we call that a deep bite or an overbite. So yeah, patients come in, they always say like, I have an overbite. Well, that's actually what an overbite is. And this bottom patient has a class 2, meaning the top jaw is more prominent, or the top teeth are more prominent relative to the lower jaw. A lot of people think that this is called an overbite. It's actually overjet, meaning the top teeth stick out further out from the bottom teeth. And that's another classic bite problem that we see. Or people will come in because they are missing teeth, they have impacted teeth, or they need to get restorative with the dentist. They need a crown somewhere and they don't have room for it. Or they have a tooth that's going to need to be removed and it's going to need to be replaced later on, but the dentist wants that tooth to be someplace else for it. So this patient in this particular case has impacted teeth. You've heard about impacted wisdom teeth, meaning they're stuck somewhere in the bone or stuck behind other teeth and they're not erupting in their normal pattern or sequence, so they're impacted. This patient has impacted canines. So if you look on that x-ray on the top left, she has two teeth that are kind of overlapping all of her other teeth that are in her mouth. Those are actually stuck in the bone and they're not going to come in on their own. And so we have to do things orthodontically and in conjunction, working with an oral surgeon or sometimes a periodontist to expose those teeth and drag them into place using orthodontic appliances. And so this is how she finished on the right. So we brought those teeth from her palate to where they should be, next to her lateral incisors. And now she's got a great bite and she's got all her teeth in her mouth. This is a patient who's missing teeth. So she's missing her lateral incisors. So we've had to put her through orthodontic treatment because we had to make space and move teeth into position so that when she's old enough, she can have her lateral teeth, which you can see she's missing in this right side photo, restored. And she did on that lower photo. A restorative dentist put in some crowns to replace the teeth that are missing. So now she has a full complement of teeth and a nice big broad smile. And so those are some of the issues that we see. So the kind of procedures that we'll perform to fix some of these problems are, obviously the biggest thing that we do is we diagnose and we treatment plan. So everyone thinks like, okay, well, you just put braces, that's what you do. That's just a part of it. The most important thing that we do is diagnose a patient and adequately treatment plan them. Because when we see a patient and we're going to treat them, we're not just seeing them for one moment in time. They're not just coming to us because they broke a tooth and they need a crown, and maybe we're not going to see them again for another year until they come in for their cleaning. We're seeing them and we're married to them over the course of a year, 2 years, sometimes 4 years. And so the treatment plan that you're going to implement to get this patient from point A to point B is really the most crucial part about what we do. And so that's the most important thing. Everything after that is to get to that treatment plan outcome that we want. So we of course place braces and appliances like expanders or headgears. A lot of what we do today is Invisalign ClinCheck treatment plans and place Invisalign. So everyone knows what hopefully Invisalign is, or clear aligners. So Invisalign is just a generic word for clear aligners, like you say Kleenex or Band-Aids, but it's a clear aligner system that's digitally planned on a computer, and then those clear aligners are printed out. And so that takes up a lot of time now because everyone wants something that's more aesthetic than braces these days. And so Invisalign is where it's at. There's also lingual braces. We do laser gingivectomy. So this patient in the middle has a lot of overgrown gum tissue or gingiva around her top teeth. And there's no way you can put braces on this patient because, I mean, I can't even see her front teeth. Where would I put those braces? So we did a laser gingivectomy, and we took away a lot of the overgrown gum tissue that was there so that we could put the braces there. Sometimes we'll use a laser to expose teeth too. Like if a canine's stuck and I just need to get a brace on it, I'll take away some gum tissue with a laser. We do fixed retainers. So that's this patient here on the right. We put a wire behind the bottom teeth. That's a fixed retainer. Those are really common. I never had one. My orthodontist never gave me one, but my husband has them. So, and we place TADs. A lot of orthodontists are placing their own TADs. We used to send those out to oral surgeons, but they're pretty simple to do these days. And so a lot of times we'll just, for the sake of speed, do them in the office. And it's It's a anchorage device that we use to help us move some teeth that may be difficult to move the way we want to in other ways if we didn't have an anchor. And sleep apnea appliances are really popular these days too. And so sleep apnea is a disorder where people are just not sleeping or getting deep sleep throughout the night, and it has a lot of systemic issues associated with it. And so appliances sometimes can help alleviate that issue if it's an airway issue. And so that's really popular these days too. And so some of the things that help us get to do all these procedures, I've already spoke about some of them, but this is a laser. We do lingual braces. So this is InBrace on the bottom, which is a popular lingual brace system these days. We do high resolution photography. That's something that's definitely gained a lot of speed in the last 5 or 10 years. Our records are really important. And now with social media becoming so important and people showcasing their work on social media, everyone wants to make sure that their photography of their cases is just impeccable. Scanners. So a lot of doctors have scanners in their offices. Molds are becoming obsolete. Molds are something people used to dread getting done at the dental office because a lot of people would gag. And now we can take photographic images of your teeth and make a 3D image of it, and you don't have to ever have a mold placed into your mouth. And now a lot of offices are also buying their own 3D printers, so they can make a lot of their appliances or retainers or clear aligners in their own office without having to outsource them these days. And lastly, a lot of what we do these days is digital treatment planning. So I spoke about Invisalign. This is what I do to be able to design a patient's smile on the computer so that when their Invisalign comes, all of the treatment planning has been done already. So what you see on the right is their initial bite. This is what the patient comes in looking at. And what you're seeing on the left is where we want their teeth to go. And a lot of back and forth occurs on this platform in order to move patients' teeth in a way that's practical and biologically sound, aesthetically pleasing, of course, and has mechanical requirements. So moving teeth isn't just like, okay, I want this tooth to go from here to here, let's just move it. There are requirements biologically and mechanically that are involved in getting that tooth from that point to this point. And so all of that has to be planned here on the computer, or when you have braces, we're doing that in the mouth in real time. So the typical types of cases that we do treat are either phase 1 treatment. So a lot of patients come in, and you really should be seeing children at an age of 6 or 7 for their first orthodontic consult, even if they don't really need anything. People usually think that you need to have all your baby teeth out of your mouth to see the orthodontist. And that's actually really not true and a bad idea. Because if there is a skeletal issue, like we spoke about, orthopedics, a lot of us deal in orthopedics and growth modification. If a patient's skeletal growth is not occurring normally, you want to intervene and you want to start treating that problem at an early age while that skeleton is still malleable, while you can still direct where growth goes. So a lot of phase 1 treatment is an expander. Maybe a patient has a narrow upper arch, a narrow palate, and you want to expand it. This is something that really has a time limit on it. You have to do it for a child. You can't do this on a 50-year-old person without a surgical intervention. Or maybe they have a class 3 where their lower jaw is growing at a very rapid pace for a young person, and their top jaw is not growing as much. And so you want to try and correct that while you can. So that's a phase 1 treatment. It's not like braces on every teeth. It's usually braces on a few teeth and some kind of appliance to address a growth issue. Full treatment is obviously when you see patients with all braces on their mouth. So that's comprehensive treatment. It could be a phase 2, meaning maybe these patients had an expander when they were 8 and now they're back for braces now that they're 12. Or it could be Invisalign, lingual braces, or sometimes surgical treatment. And then we do limited treatment. So maybe, like I said, a dentist wants to put a crown in a spot where a tooth has been missing for 20 years, but the tooth behind it is is growing into that place and the dentist just can't get that crown or that implant where it needs to go, well, they'll send them to us so that we can orthodontically separate the teeth and create room so that now that patient can get a crown or an implant placed in the correct position. And so that's a restorative treatment, and they don't get braces everywhere. Maybe they just have braces on 3 or 4 teeth to get a job done, and it's a shorter period of time. So these are some cases that I'll go through. I think I have 4 of them. Like I said, the AAO recommends that a patient gets seen around the age of 7 for the reasons that I previously mentioned. And the issues that we'll typically look at, why patients should be seen around the age of 7, well, sometimes they have a crossbite like I spoke about, so they'll need an expander. Sometimes they'll need a headgear because either their top or lower jaw is growing disproportionately from the corresponding jaw, so we have to correct it with some kind of headgear. Maybe there's an eruption issue, so teeth come in a certain sequence. Doesn't always have to chronologically, your dental age and your chronological age don't always have to match up, but there is a sequence and a symmetry to the way that your mouth works. And when there's a deviation from the sequence, it's usually a heads up that something is going on, and you have to take a panoramic issue a lot of times to see what that problem is. So a lot of times the issues that come up are they're missing teeth, or they have a cyst, or they have extra teeth. Like this middle picture, this patient's front tooth was not coming in, and he's already 10 years old. That there's a problem if you're 10 and one of your front teeth have not descended yet. That front tooth's typically in anywhere between the age of 5 to 8 years old, if I want to be generous on that range. And so the problem is that he has a supernumerary tooth. He has an extra tooth that's blocking that tooth from coming down. And these are some of the issues that we'll see in the office. And they're great to catch earlier, because if we catch it early, then we can resolve the problem and that tooth will come in normally, rather than having a 12-year-old walk into the office with a front tooth missing that they have to go through junior high school or maybe into high school without a front tooth. I mean, especially in the age of social media that we live in now, I don't think anyone wants their kid to be missing a front tooth for that long. Habits, a lot of patients have habits, so they have a tongue thrust, or they have speech issues, they suck their thumb, they suck their fingers, so we'll sometimes have to put in habit appliances. And teeth impactions, like I said before, an impaction is when a tooth's growing in incorrectly, and so you want to catch it early and try to remedy it if you can. So this is a case where the child has a large lower jaw relative to his upper jaw, so that's a class 3. And so he got a protraction headgear. It's something that he wears at night. He doesn't wear it to school, so he doesn't have to look crazy at school, but he wears an appliance to bed that helps modify the growth of the top jaw in an effort to stimulate or direct its growth while it's growing the most, so that it can come out and in front of the lower jaw. So you see his first photo where his top teeth are on the inside of his bottom teeth. And now on the right side, after 12 months of wearing his headgear, his top teeth are out and over his bottom teeth. And hopefully he continues to grow in a proper way. And sometimes they do, and sometimes they don't. A second case that I'll show you, this is an Invisalign case that we did. So we have a lot of teens in Invisalign, so we obviously have a lot of adults in Invisalign also. And this is a 26-year-old man who was a borderline surgical case. He has some of those issues we spoke about. So his top teeth and bottom teeth don't overlap. That's an open bite. His back teeth are on the inside of his bottom teeth, so that's a cross bite. And his top teeth stick out way in front of his bottom teeth. That's a class 2. And so we did Invisalign treatment on him. I think this is a fast case, actually, maybe like 16 months. So just under a year and a half, because this guy was a beast wearing his aligners. I mean, he was awesome. And so we were able to correct his bite issues and his alignment. And he has fixed retainers at the end. So those are the permanent retainers you see glued on behind the top and bottom teeth. And in addition, he wears retainers to bed to help hold all of his teeth in place. So this is a comprehensive plan. We're treating all the teeth. We're treating the bite. It's not just something on a 7-year-old to fix an individual problem. And that's the majority of our cases, comprehensive cases. This is another case. I combined a braces case, because everyone kind of knows what braces look like, with a surgical case. We have a lot of surgery patients who did not come to see their orthodontist when they were 7 years old. So they never got, a headgear or any type of Herbst or any growth modifying appliance. And he obviously either didn't get braces or never wore his retainers. Let that be a lesson to you. So he has very crowded teeth, but in addition to that, his top jaw is way out in front of his bottom jaw. So even when his teeth are lined up, and you'll see when his teeth are lined up, they're going to look way worse. His top teeth are going to look way, way, way out in front of his bottom teeth. So yes, they're nice and straight, but his top teeth are going to walk into a room before the rest of him does. And so, I mean, it's a trade-off. What's one aesthetic issue for another aesthetic issue? And beyond that, it's a functional issue. So, it's not just the way that these patients look. Orthopedics is not just for the sake of having nice straight teeth. It just so happens that when your teeth do fit together nicely, they do look better. But that's not the primary issue that orthodontists care about. They care about the bite. They care about the function, the way that your teeth fit together. If your heart is not functioning the way it should be, maybe you feel great at 20 and 30 and 40. But at some point, that lack in function is going to catch up to you. When you're 50 or 60, a doctor is going to tell you one day that you need something replaced in your heart. There's a valve that needs replacement. So things that don't function normally don't last long. If your teeth are not functioning normally, then they're not going to last long. That's when you start having teeth that are broken down and root canals and go missing, TMJ issues. So there's a functional aspect behind this that's really the primary goal of orthodontics, and everything after that is icing on the cake. So he had braces for a certain period of time. You see how his top teeth are way out of in front of his bottom teeth once his top and bottom teeth are lined up. He had a surgical procedure to reposition his lower jaw and top jaw back into place so they fit together properly. If you look at the x-ray, you can see all of the hardware that was placed by the oral surgeons in the emergency room, in the OR. And so this is a typical surgical case that we see, and this is the sequence of events that we take. And then that other case that I told you about is a limited case. So it's to facilitate other types of dental treatment. And the one I'll show you is in the case of a patient who was missing lower teeth for a very long time. And so when you're missing your bottom teeth or any teeth for a certain amount of time, since there's nothing countering the other teeth on either side, those teeth will move because there's nothing holding them in place. So this woman's top teeth have moved down so much that no dentist was able to put any implants or crowns below them to restore the teeth that were missing. And this was a young woman, she was in her 20s. So we used a TAD, and a TAD is a temporary anchorage device. It's a miniature metal screw that's like a limited form of an actual implant, but it doesn't osseointegrate, doesn't become one with your bone like a regular implant does. So I have a picture of one that I put into my mouth. I looked in the mirror and I screwed it in, and I still have it. Surely, I don't know if you can see it. But I use it as a teaching tool to show my patients, because we do have to place a lot of TADs, and hearing, oh, I have to put a screw or an implant in your bone can be a little frightening. And so seeing that I have one, I think alleviates a lot of the fear. So placing that TAD, and you can see where the arrows point to each TAD, we use it like an anchorage slingshot to bring up those back teeth. It happens very quickly because those anchors are very strong. So this took about 6 months. And you can see that on that bottom photo, those teeth have really sufficiently moved up and away from the bottom arch. And then the dentist was able to put implants and crowns there. And so her back teeth and her occlusion are fully restored. And she was able to get everything done within a year. So my advice to our future dentists out there is, there's a lot of pressure when you're in school to be the best, to do the best. I think you guys all feel like you're in competition with each other. And you'll see when you get into dental school, the competition is brutal. Like everyone, some people just don't care and they just work hard for themselves. And then there's some people who would push their mother down a flight of stairs for a great grade, you know? So I've always followed this, but you really should just work hard for yourself. I've always worked really hard. I like getting good grades, but I never intended on specializing. I liked getting good grades because I just needed to for my own mind, and I didn't really care about what anyone else was doing. You really should be your own competition. Sometimes the road taken isn't the one mapped. I think we all like to plan, plan, plan. Half of the things that have happened to me for the good were things I didn't plan on. I didn't plan on becoming an orthodontist or a specialist. It just kind of happened. I listened to some good advice and I did it. I didn't plan on working in a dental office and becoming a dentist. I thought I was, gonna work in fashion or business, and here I am today. And so that's one thing. Sometimes follow your gut and just trust in what you think is an opportunity that you shouldn't miss. But be sure that you like it, because it's a huge financial commitment and it's a huge time commitment. You're spending eternity in school. Dental school's really rough at a time when all of your peers are graduated college and making money and going on trips. Well, maybe not during COVID, but I missed out on a lot. And so dental school is your early 20s, and you're going to be home studying and people are going to be partying on Saturday. And that's just the way it is. And so you're going to miss out on a lot and you're going to go broke doing it, because it's really, really expensive. And unless someone's paying for it for you, you're taking out a lot of loans. So make sure it's something you think you really want to do and enjoy the journey. Like I said, my 7 years spent getting to the end of my career were my youth. They were my 20s. And so I had an awesome time. I had a great time in dental school. I made great friends. We worked really hard and we partied really hard, and residency was great. And so enjoy them, because that's your youth. And before you know it, you're going to be 36 with two screaming kids outside, and, COVID too might happen. So enjoy the ride.
Dr. Bonaiuto, thank you so much for such an informative session and presenting unique cases. I'm now going to hand the floor over to Kathleen, which she's going to be reading some questions for, I believe we have about 7 minutes, if
Okay.
that's cool with you.
Yeah.
Okay, awesome. So our first question is, does the orthodontic residency pay?
There are some residencies that do pay. They're hospital-based residencies, so sometimes they're a little bit more time demanding. Maybe you're on call, maybe you're working the night shift in the ER or something like that. But there are some residencies that pay. Mine did not. It was not hospital-based, and so I had to pay to go to residency. That's a great question.
Do you think it's possible to work as a general dentist out of school while attending residency?
It is possible, and I know some people who did work while they were in residency. Sometimes it's difficult in terms of time balance. And you're usually in school during your daytime hours during the week. So that means that you're either working at night or on weekends. And you have to find offices that have those kind of hours that make sense for you to work in. I did start working during my just at the end of my second year of residency. So I worked for a good year while I was in residency, but I did it doing orthodontics, not general practice.
After finishing residency, what is it like finding a job? Is it hard to find a job in a specific part of the country?
I think every part of the country is really different. The Northeast, specifically the New York City greater area, is really tough. There's a ton of dentists and orthodontists. There's a ton of every specialty, honestly. And so what I did is I looked through like the database for all the orthodontists that were working in areas that I wanted to live or work. And I just sent out a huge amount of resumes to them. Maybe someone was looking for an associate, and none of that worked. No one called me from those. But you're going to speak to your reps. You're going to meet a lot of reps. You're going to make a lot of connections. You're going to go to meetings during your residency and talk to doctors at these meetings, talk to other friends. And a lot of getting a job, in my opinion, is word of mouth and speaking to other people and doing it that way. And so that's how, and your association sometimes will send out emails and newsletters saying, hey, there's a job opportunity here. So that's typically, I think, how a lot of people find their jobs.
Can you be an orthodontist even if you're not at the top of your class? Like, how competitive is it?
Totally. I mean, it is really competitive. You know, one of the things that does set you apart are your grades. I mean, it's hard to say that that's not a major role, but it's not the only role. And you're going to go on interviews. And I think everyone here knows that sometimes you can have people that sat with their head in a book and studied endlessly, and these people have no personalities, they have no common sense, maybe they don't have great dexterity. It's a combination of a lot of things that makes you a great dentist or a great orthodontist. It's not just your grades. So it's just one piece of the equation. There's a person behind that, and when you go on your interviews, you should show that off. You know, be yourself. And you know, everyone has their own qualities that make them great, and nothing beats, you know, talent and working hard more than natural talent and grades more than just showing that you are a genuine hard worker. Like, I think hard work is more important than anything, really.
How was your orthodontic residency experience different than dental school?
You have a lot more free time, so you're not in dental school. The first 2 years you're didactically really, really, really heavily overloaded. So you're doing all the didactics that your medical students are doing. And then you have your labs that your medical students don't have, because you need to learn how to do a crown preparation, how to do a root canal, orthodontics. There's this whole world to dentistry that has to be performed in the lab with the anticipation that you're going to perform it on real human beings in a couple of years. And so that takes up a lot of time. There's a million tests. I remember there was this one February in my second year. February has like, what, 28 days? We had like 30 tests that month. There's not even enough days for that many tests. Like, it was just grueling those first 2 years. Your second 2 years are a little bit more lax because you're in clinic working on patients, but you're working really crazy because you have a lot of requirements that you need to graduate. And so your 4 years of dental school, I think at most schools, are very, very, very demanding. Your orthodontic residency is a little different. You know, you're treated more like this is your job, and you have a lot more free time. There's not a million tests, but you have tests, you have to study. A lot of people are doing their masters. You will have a thesis and a research project that you have to work on and present at the end of your 2-year residency. Some are 2-year residencies or 3-year residency. But you have a lot more free time to yourself, and so it's a little different.
Even as an orthodontist, do you ever perform general dentist procedures, or do you refer?
Most of the time you refer, but there are sometimes a procedure or two that you have to do. Like, sometimes I'll do aesthetic bonding when it's the end of a case and a patient's getting their braces off. Because I'm going to be making retainers, and I just want to make sure that that restorative is there. And I just let them know, like, hey, this is a temporary restoration, but you should go see your dentist to get something more proper done. But every once in a while, you're doing some type of minor procedure. I do still give anesthesia because I place TADs, and depending on where they are in their mouth, it's a block or it's a local infiltration, which you don't kind of really need for a TAD placement, but patients feel more comfortable and at ease with it. Or sometimes for gingivectomies, I have to do it. But I mean, I haven't done like a root canal in a century. And if someone asked me to do it, I wouldn't even know where to start tomorrow. So,
What qualifications do you need to become a dental assistant?
well, I mean, I was a dental assistant a really long time ago in Brooklyn, and I was I was 15, like I had no qualifications. Today, it's a little different. Like people need to get working papers to work anywhere if you're a teenager these days. And for dental assisting, you kind of learn on the job and you gain hours that way, and then you can become a certified dental assistant. And maybe I think there's like a test you take, but I don't really know the 100% about like what it takes to become a dental assistant.
So it looks like that's all the time we have. Dr. Bonaiuto, thank you so much for joining once again. And thank you everyone for joining our session today. Tomorrow we have a session as well. And our quiz will also be posted in our live stream and on our link tree. So please make sure to go check that out. And on that note, I hope everyone has a great night. Thank you once again for joining.